Morning, everybody. Welcome to Grand Rounds. Welcome to all you online. Uh, Welcome to all the brave souls who braved the snowstorm and showed up in person for Grand Rounds. I'm going to be introducing myself today because I'm giving the Grand Rounds. You all pretty much know me, but I'm Trevor. I was born and raised in Walworth, a small town outside of Rochester, New York. So days like today are my cup of tea. Um, and I went to undergraduate at the University of Pittsburgh. Was there until 2017 when I got into VCU for med school. Did VCU for med school, and now I'm here for residency as well. I'm one of the fourth year residents. Very much looking forward to finishing up training and moving into my early career. Um, yeah, I think that's a good introduction. So, welcome to my grand rounds. I'd like to talk today about the epidemic of physician burnout. We'll talk about the causes, impact of this epidemic, solutions that may be out there, and we'll try to focus a little bit on PM&R, though the literature that's available in PM&R for burnout is a little bit limited. So first, we're going to watch a quick video. This will kind of tee us up a little bit. It worked. No, 1 second. All right, let's try again.
Sir, you wanted to see me? Yes, Bill, please, come in. Okay. Bill, it's been brought to my attention that you haven't done any of your resiliency modules. Oh, yeah. You do know that physician burnout is a huge problem right now. Yeah, I know. So what do you think we should do about physician burnout? More days off? No, a mandatory 8-part online curriculum designed by people who have never taken care of patients. Really? That's the best way? Of course it is, but how can we measure your gains in resiliency and ultimately publish it in the New England Journal if you don't finish the modules? I mean, I could just tell you right now it's not going to make me feel better. Whoa, we'll let the 4-page self-assessment questionnaire answer that. Oh, God. What if I don't do it? Well, then you'll have to complete a 3-hour course on the importance of professionalism. Fine, but can I at least have the afternoon off to finish the modules? No, you can become resilient on your own time.
All right. I have no disclosures. So, what exactly is physician burnout? The AMA defines burnout as a long-term stress reaction that can include any of the following three cardinal symptoms. One, emotional exhaustion. Two, depersonalization. In other words, lack of empathy for or negative attitudes toward patients. Or three, diminished feeling of personal achievement. Physician burnout has grown to the level of an epidemic in the U.S. healthcare system. Estimates vary, of course, but depending on the source, per the AMA 2022 National Benchmarking Report, 51% of respondents reported that they were experiencing at least one burnout symptom. The highest levels of burnout were reported by respondents within about 6 to 10 years out of residency. So how do we measure burnout? We have three standardized tools, but most commonly we use the Maslow Burnout Inventory, which was first developed in the 1970s by Dr. Christina Maslach and her colleagues at UC Berkeley. The MBI consists of 22 items divided into three subscales: emotional exhaustion, depersonalization, and personal accomplishment. Emotional exhaustion subscale evaluates for feelings of being emotionally overextended and tired out by one's work. Depersonalization refers to or is used to evaluate for unfeeling and impersonal response toward recipients of one's service, care, treatment, or instruction. So for us, that refers to our patients. And three, personal accomplishment. This is used to assess feelings of competence and successful achievement in one's work. It's important to acknowledge that the risk of bias is inherent in self-reporting on surveys like this. So Maslow notes in her initial description of the MBI that in order to avoid bias in the responses, the survey should be administered in a controlled environment that allows for respondent privacy and confidentiality, and avoids sensitization to the topic of burnout by presenting the survey as a measure of job-related attitudes. It's for this reason that the official test form that's often administered to medical personnel is labeled as the MBI Human Services Survey. We have other standardized measures, the Copenhagen Burnout Inventory and the Well-Being Index, for example, but these are less commonly used and often are used only as a supplement to the MBI. A 2012 study by Shanafelt et al. Used the MBI to measure the 3 accepted burnout indices in a large sample of physicians from a wide variety of specialties. And a study found that among more than 7,000 physicians surveyed, a high level of emotional exhaustion was reported by 37.9% of respondents. A high level of depersonalization was reported by 29.4% of respondents. And a low sense of personal accomplishment was actually reported by just 12.4% of respondents, which kind of hints at the idea that a sense of personal accomplishment is developed independently of the sense of emotional exhaustion or depersonalization. The study also screened for depression using validated measures and found that 37.8% of respondents screened positive for depression. And they also screened for suicidal ideation and found that 6.4% screened positive for SI, which is concerning in and of itself. So what causes physician burnout? From the available literature, it seems largely a byproduct of organizational and systemic issues, including but not limited to inefficient EMRs, increasing non-clinical tasks, unskilled clerical work, and other administrative burdens placed on the physician. Dr. Christine Sinsky, one of the current leading experts on physician burnout, said that while burnout manifests in individuals, it originates in systems. Burnout is not the result of a deficiency in resiliency among physicians, rather it's due to the systems in which physicians work. In fact, physicians have been shown to have higher resiliency than the general US working population. First, what is resilience? According to the American Psychological Association, resilience is the process and outcome of successfully adapting to difficult or challenging life experiences, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands. A study by West et al., from which you see a table here, published in JAMA in 2020, compared resiliency in employed physicians to that of the general US working population, using a standardized 2-item Connor-Davidson resilience scale. The scoring of this CDRS is based on the sum of scores from 0 to 4 for each item, with a 0 indicating that the characteristic is not true at all, and 4 indicating that it is true nearly all of the time, for a total range of 0 to 8. 0 indicating the lowest resilience level, and 8 indicating the highest resilience level. And West found that the total resilience score was greater among employed physicians than among the general working population. As you can see highlighted, 6.49 in the physicians and 6.25 in the general working population. The same study by West et al. Found that physician resilience was inversely proportional to the level of burnout as measured using the 2 components of the MBI that correspond. Sorry about that. Using the 2 components of the MBI that correspond to negative impact. In other words, emotional exhaustion score and depersonalization score. Taken together, these results suggest that higher levels of resilience might be somewhat protective against burnout, We've already seen that physicians are not collectively deficient in resilience and actually seem to have higher resiliency than the non-physician workforce. However, as we'll see, even the most resilient physicians are at substantial risk of burnout, and that resiliency cannot be the sole focus of efforts to mitigate burnout. Before we move on, I wanted to point out some interesting additional findings from that West paper. West and his colleagues found that resilience scores increased with each increasing age group, implying that older physicians were more resilient than younger physicians. The boomers and Gen Xers who are listening, you did hear that right. Furthermore, West also found that those in primary care had slightly lower resiliency scores than those not in primary care. They also found that those who do not take night call had the highest resiliency scores, and those who work in academic medical centers and veterans hospitals had the lowest resiliency scores. We're not going to get into any further discussion of those differences today, but it's just some food for thought. So where does our specialty come in? Comes in pretty much near the middle. The table is cut off in the on the slide, but with PM&R at the bottom there, it's actually in the middle, and below that you don't see is urology, psychiatry, dermatology, general internal medicine, radiology, family medicine, general peds, etc. So PM&R falls right in the middle. What kind of things worsen physician burnout? For one thing, times of severe population level stress and uncertainty definitely do not help. This is a figure from December 2022 paper by Shanafelt et al. Notice that from 2011 to 2020, the level of burnout in physicians was higher than that of the general population, but it still did run parallel to it. Over the same period, the level of satisfaction with work-life balance was lower than that of the general population, but did run parallel to it. However, an abrupt rise in burnout and decrease in satisfaction with work-life balance was seen when these same physicians were surveyed again in 2021 in the midst of the COVID-19 pandemic. Additionally, they found a modest rise in depression scores during this same time period, which correlated to an abrupt rise in reported emotional exhaustion and depersonalization. What is physician burnout not? The most recent ICD classifies burnout as an occupational phenomenon, a syndrome caused by chronic, sustained, poorly managed workplace distress. It's not a medical condition or a psychiatric disorder. Nor is it the same as compassion fatigue, which is defined as the emotional, physical, and spiritual distress resulting from chronic exposure to the suffering or trauma of other people. It, of course, would seem fair to assume that a large percentage of those struggling with burnout may be either susceptible to compassion fatigue or may already be suffering from compassion fatigue. These are not mutually exclusive. So we mentioned our middle of the pack resiliency scores in PM&R, but what about burnout specifically? Surely there's no real burnout among physiatrists, right? Surely we have too much money and more than enough relaxation time in order to not be susceptible to burnout, right? Not quite. This systematic review, published in the Journal of Rehab Medicine in 2019 by Bateman et al., examined the prevalence of burnout among specialists and trainees in physical medicine and rehabilitation. Bateman and her colleagues analyzed data from 5 surveys conducted between 2012 and 2019, encompassing a total of 1,886 physicians. Notably, these 5 studies made up the bulk of the available PM&R specific literature on burnout at that time. As you can see from the table, a variety of measures were used, but questions from the standardized MBI were used as a primary measure in all 5 of the studies. Findings revealed that burnout rates ranged from 22.2% to 83.3% among PM&R trainees, and from 48% to 62% among PM&R specialists. Bateman concluded that more than half of PM&R physicians overall experience at least one symptom of burnout, highlighting the need for further research to understand its causes and to develop effective interventions. So what causes PM&R physicians to experience burnout? One of the aforementioned 5 PM&R specific studies gives us a little insight. Slua et al. In the Purple Journal in 2019 characterized factors that physiatrists felt contributed to their burnout. The study noted that a variety of factors, including increasing regulatory demands, workload, and job demands, and practice efficiency or lack of resources, were the causes that physicians most often identified as contributing to burnout. They found that, unsurprisingly, higher rates of burnout were associated with higher levels of job stress, and longer hours of work per week were associated with higher rates of burnout. Whereas higher job satisfaction increased control over workload, professional values being better aligned with those of department leaders, and allowing sufficient time for documentation without excessive need to take work home, were all associated with lower levels of burnout. Burnout was not significantly related to any specific individual factors such as age, sex, or number of years in clinical practice. A little more on various stressors that are not necessarily exclusive to PM&R, but are certainly among the most commonly reported. A 2014 article by Bodenheimer and Sinsky summarized findings from a variety of surveys of family physicians, internists, and EM docs between 2019 and 2014. And what did they find? For one, they found that 25 to 50% of family physicians' time in the exam room with the patient is spent attending to the computer. Additionally, 43% of physicians reported spending more than 30% of their workday on administrative tasks and non-face-to-face activities like inbox management, letters, med refills, etc. They also found that primary care physicians at VA facilities spent an average of 49 minutes per day responding to inbox alerts, and at least half of such alerts could have been handled by other staff. They found that 44% of the workday for EM docs was found to be spent doing data entry, with upwards of 4,000 clicks per day in the EMR. Only 28% of the day was spent with patients. And they found that more than 75% of physicians reported that the EMR increased the time needed for planning, reviewing, ordering, and documenting patient care, severely decreasing the time available for face-to-face patient care. While these surveys are done in non-PM&R physicians, they're very much in keeping with the personal experience that many physicians in our specialty have on a daily basis. A little more on what causes burnout among physicians of all kinds. In his 2015 article in the American Academy of Family Physicians, Dr. Dyke Drummond laid out what he felt were the 5 main causes of physician burnout. Number 1 was the practice of clinical medicine. Being a physician is stressful. We deal with sick and injured people every day. The lives of our patients are heavily impacted by their health issues, and we spend a lot of time managing their psychosocial needs in addition to their physical needs. Our work takes significant energy, even on good days. Number 2 was your specific job. Each job has a unique set of stressors. Number 3 was having a life. We're rarely, if ever, taught work-life balance skills during our medical training. Additionally, any number of situations can arise outside of work that cause home to switch from a place of recharging and recuperation to an additional area of stress. These include, but are not limited to, conflicts with family, illnesses, financial pressures, etc. Number 4 was the conditioning of our medical education. Some of the same traits that are generally necessary for our success in medical training ultimately set us up for burnout down the road. A tendency toward being workaholics, trying to be superheroes, being perfectionists, sometimes feeling like we have to be lone rangers, the idea that the patient comes first and we must never show weakness. And number 5, finally, was the leadership skills of your immediate superiors. You might have heard the saying that people don't quit companies, they quit their boss. A study by Shanafelt in 2015 showed a direct relationship between the quality of your boss and your burnout and job satisfaction levels. They found that each 1 point increase in composite leadership score was associated with a 3.3% decrease in the likelihood of burnout. And they also found a statistically significant finding that there was a 9% increase in the likelihood of satisfaction of the physicians supervised. Drummond also described 3 types of energy accounts we all have inside of us, from which we make deposits and withdrawals every day. The first one was your physical energy account. This is where we make deposits through rest, exercise, and good nutrition, all things that weren't necessarily emphasized in the environments in which most of us trained. We constantly educate our patients on the importance of these things, but we're often not given much time or space in which to focus on them for ourselves. Second was your emotional energy account. You make deposits in this account by maintaining healthy relationships with friends and loved ones. Recharging here is essential if you're to have the energy necessary to be emotionally available for your patients, staff, family, and friends. And number 3 that he pointed out was your spiritual energy account. You make deposits in this account by connecting with your personal sense of purpose. If this account is drained for long enough, you may have trouble finding a reason to carry on. Burnout is the constellation of symptoms that occur when your energy account has a negative balance over time. You can continue to function in this depleted state. However, you're probably going to be a shadow of the doctor you are when your account has a positive balance. A 2012 study by Shanafelt examined burnout rates among physicians versus the general workforce. This was a national study conducted in a large sample of U.S. physicians, more than 7,000, from all specialty disciplines. They also surveyed a probability-based sample of the general U.S. population for comparison. They used validated measures, specifically the MBI, and what did they find? They found that 45.8% of physicians reported at least one symptom of burnout. Could this actually be underreported because of the show no weakness mentality we discussed earlier? Just food for thought. They also found that physicians were significantly more likely to have symptoms of burnout, 37.9% in physicians versus 27.8% in the general population, with the highest rates among physicians at the front line of care access, such as family medicine, general internal medicine, and emergency medicine. Some interesting points for consideration. They found a statistically significant relationship between burnout and highest level of education completed. Compared with high school graduates, individuals with an MD or a DO degree were at increased risk for burnout, with an odds ratio of 1.36, whereas individuals with a bachelor's degree, a master's degree, or a professional degree or doctorate other than an MD or a DO were actually at lower risk for burnout, all with odds ratios of under 1. The burnout rate among PM&R physicians surveyed was slightly above the mean, consistent with the idea that PM&R now ranks in the upper echelon of specialties with the highest prevalence of physician burnout. In this same study, Shanafelt also examined work-life balance by specialty in comparison with the general workforce. Differences in satisfaction with work-life balance were observed by specialty as seen in this figure. Physicians practicing dermatology, general pediatrics, preventive medicine, etc., including occupational health and environmental medicine, have the highest rated satisfaction with work-life balance, whereas physicians practicing general surgery, subspecialties in general surgery and obstetrics gynecology had the lowest rates of satisfaction with work-life balance. Again, PM&R physicians were slightly less satisfied with their work-life balance compared to the mean. They also found a large difference in level of dissatisfaction with work-life balance in physicians versus the general population. 40.2% of physicians surveyed were dissatisfied with their work-life balance, whereas just 23.2% of the general workforce surveyed were dissatisfied with their work-life balance. Dissatisfaction with work-life balance was similar for men versus women among the population controls, roughly 23% for both men and women, whereas female physicians were slightly more likely to be dissatisfied with work-life balance than their male colleagues, 43.1% versus 38.9%. A little more on sex differences later. So let's talk about how physician burnout affects the idea of medicine as a calling. In a 2016 study, Yeager et al. Found a statistically significant inverse relationship between burnout and the sense of medicine as a calling in physicians. Compared with physicians who reported no burnout symptoms, those who experienced burnout had lower odds of 1, finding their work rewarding, 2, seeing their work as one of the most important things in their lives, thinking their work makes the world a better place. Burnout was also associated with lower odds of enjoying talking about their work to others, saying that they would choose the same career again if they had a do-over, and saying that they would continue with their current work even if they were financially taken care of but no longer received a paycheck. This data confirms what we already know from common sense, namely that burnout erodes the intrinsic motivation that drives many physicians to enter medicine. The erosion of this sense of calling may have adverse consequences for physicians and their patients by worsening job dissatisfaction and increasing physician turnover. This study highlights the need for a workplace culture that supports professional fulfillment. In a 2011 study, Hoax et al. Used PM&R to assess for differences in the onset and prevalence of burnout between male and female physicians. The study sample consisted of 212 general practitioners in the Netherlands, so generalizability is limited, but we can certainly theorize about how similar results might be shown by a larger study including physicians of all specialties in the United States. As you can see in the figure on the left, the trend of clinical burnout in women mirrored the trend of clinical burnout in men, though a higher percentage of men overall experienced burnout. However, the catalyst for burnout was different between men and women. For women, emotional exhaustion appeared to be the most significant important factor in development of burnout. For men, depersonalization seems to be the most important factor. Hoax also includes an interesting and potentially controversial discussion of gender socialization theory and how it might explain the difference we've just discussed. He wrote that gender socialization theory poses that among boys and men, assertiveness and independence is stimulated, just as repelling feelings of vulnerability. They are taught to be aggressive, non-emotional, and goal-oriented, and to not show weakness. This socialization may lead to the incapability of men to solve internal conflicts and to their repression of internal conflicts, which may in turn lead to higher chances of depersonalization. For women, it's stated that gender socialization leads to attitudes of tenderness, sharing, being considerate and kind, and to repelling aggressive behavior. And that's from Hoax's 2011 article on BMC Public Health. So all other factors being equal, Hoax posits that male physicians tend to develop burnout through a depersonalization response to stress, whereas female physicians tend to develop burnout due to emotional exhaustion that results from chronic stress. And that maybe burnout can be mitigated by recognizing early warning signs and tailoring burnout prevention strategies to gender-specific triggers. That's all we'll say about that for now. So what about how burnout affects the delicate balance between work obligations and home life? In 2013, Derby et al. At the University of Colorado School of Public Health conducted a survey of physicians and their employed partners in order to gauge burnout, quality of life, depression, as well as satisfaction with career, work-life balance, and personal relationships, and the experience of work-home conflict. For their purposes, they defined work-home conflict as the need to perform both work and personal related tasks and responsibilities simultaneously, resulting in conflict between work and home. Their results included the finding that 44.3% of physicians and 55.7% of their employed partners reported experiencing work-home conflict in the preceding 3 weeks. Derby included a study of factors that were independently associated with work-home conflict. And they found in this study that increased work hours for both physicians and partners were independently associated with higher likelihood of work-home conflict. Specifically, they found an odds ratio of 1.31 for each additional 10 hours worked by the physician and an odds ratio of 1.23 for each additional 10 hours worked by the employed partner. Interestingly, they found that the likelihood of work-home conflict appears to decrease slightly with every year older the physician gets. So younger physicians appear to have a higher likelihood of experiencing work-home conflict than older physicians. And they found that physicians who worked in an academic medical center were significantly more likely to experience work-home conflict than those who were in private practice. In this same study by Derby, those reporting recent work-home conflict also exhibited higher rates of clinical burnout. 47.1% of physicians reporting recent work-home conflict versus 26.6% without recent work-home conflict, and 42.4% of employed partners with recent work-home conflict versus 23.8% without. Other notable findings from this study include a whopping 50.4% of physicians reporting recent work-home conflict that also screened positive for depression. So did 42.4% of employed partners with recent work-home conflict. Additionally, a not insignificant percentage of physicians and their employed partners who reported recent work-home conflict also had seriously contemplated separation or divorce. It was 14% in those that had work-home conflict versus 13.7%, which was higher than the percentage among those who reported no recent work-home conflict. Only 78.2% of employed partners reporting recent work-home conflict said that they would choose a physician for a partner or a spouse if they had a do-over, compared to 82.4% in the partners not reporting recent work-home conflict. Perhaps one of the most concerning findings was that only 63% of physicians reporting recent work-home conflict said that they would choose to become a physician again if they had a do-over, versus 77.2% in those that did not have work-home conflict. The fact that less than 80% of physicians surveyed would choose to become a physician again if they had to do it over is alarming in and of itself. It supports the fact that there are real, deep systemic issues in the way that the American healthcare system approaches the role of the modern physician. So what's the takeaway from this Derby study? Work-home conflict is strongly associated with burnout, depression, dissatisfaction with relationships, and regrets about career choice. And that dual career households appear to be at a higher risk for increased stress, strained relationships, decreased job satisfaction, and work-family imbalance. Some ways that the effect of work-home conflict and burnout can be mitigated may include, but aren't limited to, reducing work hours, promoting flexible scheduling, institutional policies that support work-life balance, and support programs and/or groups for the physician and their partner. We'll begin to move toward a discussion about what can be done about the physician epidemic now. In 2008, Berwick et al. From the Institute for Healthcare Improvement proposed their triple aim as a model for improving healthcare in the United States. The triple aim defined a conversion from a physician-centric to a patient-centric medical system, and its primary goal was to improve the health of the overall population, with two secondary goals: improving patient experience and reducing costs, contributing to the achievement of that primary goal. The American healthcare system has adopted this framework in the ensuing 15 plus years by making the intentional choice to try to measure and understand the patient's experience of healthcare, in addition to looking for ways to improve the quality of healthcare with quantifiable results. This may be seen in a variety of initiatives out there, including but not limited to the honoring of patients as consumers who ought to participate fully in decision-making regarding their care, and physicians more consciously using evidence-based protocols for diagnosis and treatment. However, in 2013, Dr. William Spinelli wrote in Mayo Clinic Proceedings about his concern that the Triple Aim initiative was leaving clinician wellness out of the equation. He wrote that focusing only on the quality of patient care, total cost of care, and the patient experience of care, the Triple Aim has separated the well-being of the healthcare workforce from system change initiatives. The separation has resulted in phantom limb pain, which is often expressed as burnout. As discussed earlier, Shanafelt reported in 2012 that the prevalence of burnout in U.S. physicians is higher than in any other professionals with advanced degrees, and that the prevalence of burnout in U.S. physicians is twice what was reported in the general U.S. working population. 46% of the physicians surveyed reported at least one symptom of burnout. Numerous studies have shown that burnout among individual physicians leads to professional dissatisfaction, elevated physician suicide rates, accelerated physician turnover, and premature retirement. A 2012 Physicians Foundation study of primary care physicians reported that more than 50% of respondents considered cutting back on patient care and clinic time or retiring completely within 3 years, and 57.9% would not recommend medicine as a career to young people. It's logical to think that these adverse effects of burnout would be setting the U.S. healthcare system up for an impending physicians shortage and present a major barrier to the healthcare system's capacity for accomplishing the goals of the Triple Aim. To further drive this point home, in 2014, Babbitt et al. Published a study in the Journal of American Medical Informatics Association, which showed that more EHR functionalities such as email with patients, physician order entry, alerts, and reminders intended to promote the Triple Aim are actually associated with more burnout and intent to leave practice. Furthermore, physician burnout impairs care quality, increases costs for both the healthcare system and the individual patients, and reduces overall patient satisfaction. All of this suggests that medical practices working toward the Triple Aim may inadvertently be causing increased physician burnout and ultimately reducing their ability to fulfill the tenets of the Triple Aim. In 2014, Bodenheimer and Sinsky in the Annals of Family Medicine proposed the expansion of the Triple Aim to include physician well-being. In their article, they provide some ideas as to how this fourth aim might be implemented. So how can the healthcare system work toward achieving this fourth aim? It's not an exhaustive list, but here are some ideas that Bodenheimer and Sinsky propose. 1, implement team documentation. Involve nurses and medical assistants in entering patient data, managing orders, prescriptions, and charges, leading to higher satisfaction, improved revenue, and better team efficiency, increasing the number of patients one team can manage while also going home earlier. And who doesn't love going home earlier? You know who you are. 2, use pre-visit planning and lab testing. Reduce time spent on reviewing and following up lab results outside of the associated patient encounter. In a 2012 study, Hyland et al. Performed a systematic review of 19 previous studies regarding the follow-up of lab and imaging results in the ambulatory setting. They reported finding that up to 62% of abnormal lab results were never followed up on, and up to 36% of abnormal imaging studies. In another 2012 study, Siddig et al. Reports an average of 57 EMR alerts per physician per day. And by his estimation, each separate instance of the physician needing to review an individual result or alert disconnected in time from the associated patient encounter, then needing to spend time to go into that patient's chart, review the context of that unique encounter, and then communicate the results and/or next steps to the patient required a minimum of 1 to 3 minutes per alert, adding up to roughly 2 hours per day by his estimation. Number 3, expand roles for other medical personnel. In a 2013 article, Bodenheimer recommended empowering licensed personnel like nurses and pharmacists to provide more care under physician orders, creating standing orders for non-licensed health personnel like medical assistants, as well as assigning them preventive care and chronic care responsibilities, and allowing them to function as panel managers and health coaches. Number 4, standardized prescription refill workflows. More than 40% of patients over the age of 65 in the US today are on 5 or more medications. Inefficient management of the renewal process for these meds can end up costing hours of nursing and physician time each day. In 2012, Sinsky suggested a process of synchronized bundled prescription renewal in which the physician renews all pertinent chronic medications for a patient at their routine checkup and provides sufficient refills to last until the next routine visit, whether it's a month, 6 months, or a year. This approach has the potential to significantly decrease patient inconvenience, support medication adherence, and save lots of time for the physician and staff. And lastly, co-locating teams. Physicians working alongside team members boosts efficiency, perhaps saving about 30 minutes daily, according to estimations by Shipman et al. In 2013. A little more from Dr. Drummond. So Dr. Drummond also wrote in the article discussed earlier that in reality, burnout is a dilemma. It doesn't have a solution because it's not a problem in the first place. Dilemmas are perpetual balancing acts that require perpetual action. You address a dilemma with an ongoing strategy, not a one-time solution. While it's not only the individual's responsibility to address their burnout dilemma, and systemic changes are supremely important to reverse the trend of frustration and discouragement, addressing both internal and external causes of burnout. Dr. Drummond does provide a concise list of ideas on how to mitigate burnout at the individual physician level in his 2015 article series about the same, both in the professional environment and within the home environment. First, he suggested moving from an EMR hater to a power user. Shifting from frustration to mastery by learning from EHR power users, like Dr. Kim, for example. Observe their workflows, adopt efficiency tips, and use templates to improve documentation speed. He also suggested documenting the minimally necessary data set, focusing on essential documentation for billing, legal protection, and continuity of care, while avoiding unnecessary details and long narratives. Third, use the EHR to automate anything that you can. Identify repetitive documentation patterns and create templates to streamline charting, reducing time spent on manual entry. 4, make documentation a team sport. Delegate portions of documentation to staff, engage the team in brainstorming ways to improve efficiency, and share charting responsibilities. 5, pilot the use of a scribe. Conducting a trial with a scribe to prove its efficiency, tracking productivity data to justify making the role permanent. 6, look for additional broken record moments. Automate patient education through handouts, videos, or delegation to staff to save time and improve consistency. 7, huddle with your team. Conduct a brief, structured meeting before each session to troubleshoot potential issues, enhance teamwork, and improve efficiency. And 8, embrace batch processing. Process non-urgent tasks such as messages, labs, refills at designated times rather than allowing them to disrupt workflow, increasing focus and efficiency. On the personal front, he suggested using a life calendar, balance work and personal life by creating a comprehensive weekly calendar that includes family, self-care, and personal activities, scheduling anything you can in advance, taking a picture for easy reference, and using it to confidently say no to conflicts. Also suggested intentional quality time. Strengthening relationships by prioritizing quality time regularly, planning creatively, scheduling quality time in advance if possible, and committing to maintaining connection and enjoyment outside of work. 11, weekly bucket lists, identifying small but fulfilling activities and integrating them into your routine to boost energy and resilience. And last, but perhaps most effective, I think, is a work-life boundary ritual. Establishing a ritual to mentally disconnect from work and transition fully into personal life. This could include a symbolic action to reinforce the shift and enhance relaxation at home. For example, changing clothes and or shoes when you get home, a la Mr. Rogers. As we come in for a landing, let's think a little about the limited evidence on burnout among physiatry specialists and trainees. As of 2019, when that systematic review was done by Bateman et al., there were a grand total of 5 US-based studies into burnout within the PM&R community, including a total of 1,886 individual PM&R trainees and board-certified specialists. Despite that small data set, it was clear that there was a high prevalence of burnout already present in the PM&R field at that time. Though there was an even greater lack of data for markets outside the US, it's reasonable to think that this trend is not entirely unique to the US healthcare system. Furthermore, the limited literature available prior to 2019 showed variable perspectives on burnout, ranging from acknowledgement of its existence and risk to outright dismissal of it as a myth and just a sign of poor resilience on the part of the individual. All of this underscores the need for further research to better understand prevalence rates, explore risk and protective factors, and assess burnout outside the US. Fortunately, in the last 5 years, our major governing bodies have started to collaborate somewhat to that end. In 2021, AAPM&R announced that it was working with the ABPMR and the AAP to establish a work group to inform the design of interventions to reduce burnout and promote professional fulfillment among US physiatrists. Additionally, this initiative included a partnership with the Stanford Medicine Well MD Center led by Dr. Tate Shanafelt, who is the center's director and chief wellness officer and the primary author of several of the studies referenced in this presentation. So to conclude, it's imperative that physician burnout continue to be recognized as a significant issue within PM&R as it affects physician well-being, patient care, and healthcare institutions. Addressing this issue is critical for the sustainability of our specialty. Thank you. And the obligatory slide, thanking you and showing my wonderful support system and where I grew up. Questions? Sure.
Is there any like idea behind like the duration of burnout? So here's the thing. I just got off VA call, and every time I'm on call, I'm like a different person, and not that good way. And so I'm like, oh, everything sucks. I hate it. I didn't sleep, blah, blah, blah. And then like, give me a weekend to sleep in, and then I'll be back and I'll be so much better next week. Is there anything in the literature about like durations?
Not that so the question was, is there anything in the literature currently about the duration of burnout, whether or not it resolves with, things like rest and recuperation? I haven't seen anything to that end in the research that I've done so far. From personal experience and seeing those around me, I think that burnout is not necessarily terminal, and that it can be kind of mitigated and somewhat reversed through a lot of the interventions that you know that we had talked about in the presentation. Um, yeah. One question that some of you may have is, am I burned out? And that's an inappropriate question because it's supposed to be confidential and private. But no. Short answer is not today. Yeah. Any other questions? Dr. Carr?
Have you heard anything about like AI is up and coming, like using the soap note apps and everything? You like read anything about like whether that's efficient or I don't know, or anything about it?
It's definitely out there, and I saw hints of it in a lot of the papers that I was reading, but nothing concrete showing results from it. But I mean, I anticipate in 5 or 10 years we'll see a lot of that kind of literature out there. Probably not in necessarily in the PM&R field, but in other fields that may apply and adjuncts to our field.
I was wondering if you came across any associations between like burnout and then reasons that individuals choose a specific specialty. Because I just wonder and probably think that people get into it, for like wrong reasons. They won't have, the purpose and that intrinsic motivation. And if there was if you came across anything with like reasoning for choosing the specialty and then risk burnout.
Gotcha. Question was, have I seen any research about whether individuals choosing what specialty they go into have kind of considered burnout as a factor in whether or not they choose a particular specialty over another?
Or like the reasons that they choose a specialty. So for example, like the trope of like plenty of money and relaxation, like if people choose PM&R because of that, but then the expectations don't meet the reality, there's more risk for burnout there.
Okay. No, I don't think I've seen anything like that also. Again, I mean, even in these past 5 years, as there's been more awareness of burnout, the literature is still so limited. And even in that collaboration, that AAPM&R was supposed to be doing with the other governing bodies, it was very hard for me to find any reports about what they were doing or results that they had found or interventions that they were taking on. So all that to say, I think it's really just you hear it from the people around you or medical students that work with you on your rotations about what is causing them to consider certain specialties. And I think with PM&R we joke about plenty of money and relaxation, but I mean I don't think any of us would admit to that really being a reason that we go into it. We're certainly very patient centered, passionate about getting them back to their quality of life and all that. And I think that 99.9% of us in PM&R would take that as our motivation for choosing the specialty. Hope that answers. Brian, were there questions online?
There was a comment from Dr. Wayne, and he just commented that he brought up ideas in his grand round talk last year. And to combat burnout, he said, always be in learning mode, have courage to change or adapt practice when burnout is perceived. And he said, stay engaged in organizations that are meaningful to you. And to that, Dr. Seaver replied, 100% Doug. Find your life, quote unquote, beliefs and purpose. And thank you. And Dr. Garbo said, great job, huge advances in billing documentation requirements and maintaining certification in the last 8 years. We did an HRV study on VA ICU shift nurses as a biomarker. And then Dr. Wayne, he submitted a question that says, wonder if burnout is more likely in PM&R docs that had fellowships or practice with a very narrow focus. Seems like they potentially are more likely to lose job satisfaction sooner. Anything in literature in this regard?
Again, it's been so limited, even in these past handful of years, that no, I haven't seen anything regarding specifically, subspecialties or, PM&R physicians that have gone through fellowship necessarily having more or less tendency toward burnout than those of us that, graduate and go directly into practice and are more of a generalist. Thanks for the question, Dr. Wayne.
Trevor, did you find anything regarding successes as far as wellness programs? I think it was about a year ago, I saw a study that basically said the only successful wellness programs are those that give time back or more time away from work, which, yeah, no surprise. Doesn't make you do 8 modules like your opening joked about, but it's true. There are those wellness programs out there that make you do 8 modules. Did you find any literature about different wellness programs or approaches other than giving you time?
No.
Okay.
It's so limited, and I don't know how much time would be required to study something like that, if you would need, months to study that and find effects of that, or if you would need, years. I mean, it's been 5 years since that 2019 systematic study, and you would think that if it had been done, that there would be time enough to have results and publish them, but I didn't see anything directly related to that. But certainly from, personal experience, we can all agree that getting time back is the best way to combat our burnout, for sure. All right, well, I'm gonna end it there, but thank you so much for your time. Thanks everybody online. Appreciate y'all.